utilized. With this, I'd like to thank all my collaborators who contributed to this research.
Thank you very much, and thank you for that excellent talk. Can I just ask you the first question? So in a 15-year-old, because that's the commonest age of presentation, with a strong family history, can you just tell us what would make you look for a genetic cause?
So if there is a 15-year-old that has a very severe, for instance, fistulizing disease, if there are wound healing problems from the beginning, if there is a failure, for instance, of anti-TNF treatment, or other family members sort of have already sort of a suspicious course, then I feel it's now justified to progress. There are diseases, for instance, like chronic granulomatous disease or XIAP deficiencies that are more common in these regions, and they should be excluded. We have seen patients who really sort of had exactly this setting and who had subsequent suffering for even decades. And I feel even in a 15-year-old in a very severe setting, one should consider genomics. In the classical 15-year-old that is well treated, that has not an extreme phenotype, the likelihood to find a monogenic disorder is exceedingly low.
Thank you. Now, I've got a great question in the chat. This is from Lissy Derrida, who compliments you on your great overview and asks the important question, is there any role for genetic counseling? And I presume she means in the severe phenotype early onset patients, but what would be your approach to that?
So, yeah, this actually is sort of is one of the questions why we have thought that we need to transition from the research setting that we have done for years into clinical practice, because in the research setting what we often do is we tell patients we want to do research, very low likelihood that there will be an outcome, and we sort of are not expecting that we feed anything back because it's very unlikely that this will offer relevance to you. Now, with increasing knowledge, what is clear is that some parents are worried, they read things up, they want to know whether there is a condition, and they want to know whether there is no condition. And what we have felt sort of short in the research setting often is that we do not feed back negative findings, because that's very difficult. And similarly, one of the questions is, if there is a family with a child of IBD, what is the likelihood of having sort of, for instance, another offspring and another child? And these are settings that are best discussed in the clinical genomics setting, where a geneticist jointly with gastroenterologists can give exactly this type of counseling.
Thank you. I'm afraid we're going to have to move on, but there's quite a lot of questions in the chat, which I hope you'll have time to answer. But thank you so much for your excellent talk. We're moving on to the next presentation, and we're going to learn more and more by collaboration, data collection, and meticulous analysis. So it's my pleasure to introduce Teresa Drakowska, who is from the Czech Republic, to talk on the prediction of time to relapse in pediatric Crohn's disease patients on azathioprine treatment. And that's reporting a multi-center study of the pediatric IBD Porter group of ESPGHAN.
Hello, my name is Teresa, and I would like to thank you for having the opportunity to present our results of the study focused on prediction of time to relapse in pediatric patients with Crohn's disease on thiopurine treatment. The first picture illustrates the clinical issue which was at the origin of this project. In every newly diagnosed pediatric patients with Crohn's disease, a choice of appropriate long-term treatment is required. High effectiveness of top-down approach by initiating the treatment with anti-TNF agent has been recently proven in a randomized controlled trial held in the Netherlands. Nevertheless, this top-down approach has its limitations, such as high cost and limited duration of action of anti-TNF. Another options are thiopurines, which are effective and in comparison with anti-TNF cheaper, and while possible also being safer than in combination therapy. At last, there is a hypothetical option to leave the patient without a long-term treatment. So, reflecting this situation, our question is how to identify the patients who are the best candidates for immunomodulation therapy. The principal challenge lies in the fact that the decision has to be made at the time of diagnosis. Till now, we did not have any sufficient data to make an informed, evidence-based decision. We were aware that in order to realize this kind of project, it is crucial to obtain a large enough data set. Therefore, we decided to join with other centers specialized in pediatric inflammatory bowel diseases, and finally 13 European centers cooperated in this project. As a main data source, we used an international incidence register, EuroCase, and minority of the data that was not available in EuroCase was collected in a retrospect separately in each center. So, we started with a set of 2,241 pediatric inflammatory bowel disease patients. In the first step, 1,051 patients diagnosed with ulcerative colitis were excluded. Within the set of 1,190 pediatric Crohn's disease patients, 302 patients did not fulfill inclusion criteria and were dropped out. Further, we excluded 447 patients who met the exclusion criteria, and the final data set, which we used to search for potential predictors, consisted of 441 pediatric patients who responded to injection treatment, including exclusive enteral nutrition and corticosteroids, and who were in remission while on treatment with thiopurines at week 12 after diagnosis. Finally, 61 patients with missing data relevant to the predictive model had to be excluded, and the data from 380 patients was used to select the best final model. Since the main aims of the project were identification of predictors and the creation of predictive model based on these predictors, time to first clinical relapse was set at the main endpoint. We defined the clinical relapse as a need for reinduction of remission or development of Crohn's disease-related complications counting abscess, fistula, and clinically significant stricture. As a first result, you can see the survival curve showing the time to first clinical relapse. So according to our data, half of the patients did not experience clinical relapse within 2 years of thiopurine treatment initiation. Moreover, we can see that approximately 1/4 of patients were in clinical remission after 5 years of thiopurine treatment. Due to small sample size, it is difficult to evaluate data after 5 years, but still we can notice that there are some patients in clinical remission even after 10 years of this treatment. So, the potential predictive factors were chosen from 6 different areas. We screened patients' demographic characteristics, laboratory parameters reflecting inflammation activity, growth data, endoscopic findings, findings of radiological imaging methods, and possibilities of treatment monitoring. Within the set of these variables, we selected a subset out of which the best final model was created. The definitive model consisted of 8 predictors. Although not a clinical applicable information, center of patient's origin was strongly associated with time to relapse, and thus it had to remain a part of the model. The other predictors were ileocolonic disease localization, level of C-reactive protein, body mass index Z-score, abnormal finding on imaging examination of sigmoid, and endoscopic changes consistent with Crohn's disease and esophageal tube, all of them obtained at the time of diagnosis. Here on a separate figure, you can see the last part of the model, the interaction of thiopurine dose and patient's age. In age group of 8 to 11 years, we observe significant protective effect of lower thiopurine dose. However, based on available data, we are not able to explain this finding. In other age groups, thiopurine dose had no significant effect on time to relapse. So combining the risks, we separated patients with the worst and the best prognosis. Based on the coefficients of the final model, the high and low risk groups are defined by parameters you can see in the screen in front of you. In general, the low risk group was associated with interaction of a specific age group and thiopurine dose, higher body mass index Z-score, and normal findings on esophageal endoscopy and sigmoid imaging. Finally, we developed a web-based application to easily transfer this new knowledge into clinical practice. Using this web-based tool, The individual values of predictive model are filled in, and then the individual estimation of time to relapse on tioproins may be visualized, differing on the basis of input values. So in conclusion, we identified 6 independent predictors available in diagnosis of early tioproin treatment failure in patients who achieved remission on exclusive enteral nutrition or corticosteroids and were concomitantly treated with tioproins. We developed a model for individual prediction of time to relapse in pediatric patients with Crohn's disease using data from International Multicentric Registry. In our sample, 51% of patients maintained clinical remission after 2 years of tioproin treatment initiation. Therefore, we suggest that tioprins can still be considered a suitable treatment option for a subset of pediatric patients with Crohn's disease. And we developed web-based tool allowing easy identification of patients who are most likely to benefit from tioprins treatment. At last but not least, I would like to thank all my collaborators for all their work, time, and valuable suggestions. Thank you for your attention, and I will be more than happy to answer your questions.
I'd like to thank you for your excellent talk and meticulous presentation of the data. One of the interesting things that comes out of a data set like this is the question as to whether if 50% of patients on azathioprine are in remission at 2 years, does that suggest some of those patients didn't need azathioprine? And it goes right back to the early studies of azathioprine. So do you think that your data at least tells you risk factors for treating it with azathioprine, but also starts to inform us about the population that might not need the azathioprine, bearing in mind the anxieties about long-term toxicity?
Yeah, I'm sorry, I didn't hear the last part of the question.
I mean, that was just bearing in mind the issues of long-term toxicity. Is there, from your data set, anything that helps us decide who shouldn't have azathioprine?
Yeah, actually, based on our data, we think that there is a subgroup of patients who are supposed to use azathioprine, but we really need to be able to define this subgroup of patients. And actually, I'm not sure if we are sure that azathioprine is like more dangerous or is not safer than biologics. I think we are not able to compare it at the moment, so we don't know, and maybe we will see in the future.
It'd be great to see the next bit of information from this data set. The question from the audience is, did you evaluate the effect of TPMT activity in relapsing patients? So are there any patients in your cohort who are, for example, TPMT deficient?
Yeah, actually, we were not able to do this analysis because there was so lack of data. Actually, so many centers tested. There was almost no center who tested TPMT and TPMT metabolism, so we are not able to evaluate it because we didn't have this data.
Okay, look, thank you for your excellent presentation, and now I'll hand back to my co-chair, Eric Benchimol.
Thank you. That was a truly great study. The next presenter really needs no introduction. Most of us know Dr. Escher from Rotterdam in the Netherlands, who will present on treatment endpoints in pediatric and adolescent IBD.
Ladies and gentlemen, Mr. Chairman, my name is